Microphone, eh?
It's better to have that. Madame l'ambassadrice du Canada et vos collègues, Dr. Pachek, your colleagues and guests, and your lovely pianist. I don't know where she is. It was so nice to hear that nice music. You know, it's a real pleasure for me to be here in Croatia for the first time, and I will explain to you how it happened. Like some of you, I'm a CEO in an academic psychiatric hospital in Quebec City, Quebec province in Canada. And I'm also a surveyor for Accreditation Canada since more than 10 years. So I have two kinds of experiences to share with you. One as being a chief executive officer in an academic hospital who is evolving in a continuous quality improvement culture and patient safety culture. So I have many things to share with you on that perspective, and I have some others being a surveyor and then utilizing the standards of Accreditation Canada to survey other hospitals, sometimes in psychiatric area, but sometimes also in general or academic hospital who are not psychiatric one. I'm in the psychiatric field only since 5 years as CEO. I was before a medical director in two big teaching hospitals, one in Montreal and the other one in Quebec City. And before that, I was in family practice for almost 12 years, and after I took a specialty in public health and community health medicine, and then completed a master's degree in administration. So it's the reason why I became, at the end of my career, a CEO in a big psychiatric hospital. Why do I took that? It's because I thought that it was the kind of hospital who has the most to do to try to catch the speed that General Hospital has take the years before, and that we should learn a lot from other hospitals to make the psychiatric hospital becoming part of the, of the first one in the province. And in my mind, it should be one way to demystify mental health. And if we have a hospital who can perform like the others, I think we'll do a lot more job to have mental health services and people suffering from mental health problems being more recognized in the society. So it's the reason why I'm there since the past 5 years. Today, my presentation, I will try to have it not too long because I don't want to make you sleep after the lunch. And I will take time to share my experience by answering to your questions. So I think many of you speak English. If not, I think Drago and Maringo, because they gave me their first name, will help you produce your question and then answering the most I can your preoccupations. I will speak on three perspectives. The first one, we cannot address standards in mental health or psychiatric hospital if we don't address the whole process of accreditation, and if we do not address the way to manage a hospital and having professionals and all support services working together those years. Too much thing is growing in the world around us, so we cannot close our ears and not be attentive to what's coming on and how it can help us to go further. So I will speak about accreditation, I will speak about standards a little bit later for standards, and I will speak about mobilizing a hospital on the way of continuous improvement. Because I think patient safety, quality, for me, it's all included in continuous improvement. As far as you ask question yourself, your professional ask question, and all the support services ask question, are we doing the best thing in our field? You're starting to look at quality, and you will find, looking at quality, that you have to take in account patient safety first. In my definition, I will speak about quality improvement, continuous improvement, patient safety. For me, it's the same vector, going to the same place, having better care for the patients in a safety way, and having our resources, personnel of all kinds, having the tools they need to deliver care. So I will turn around those themes during my presentation. Is that clear at that time? Okay, that's mean you understand. Okay. So, Dr. Pausek and his colleagues asked me to, just to split the presentation that way. So we will speak first about mental health services, psychiatric hospital, and accreditation. And then after, we will go deeper on mental health standards. But as I told before, looking at the last part is only one part of the whole process to improve quality in the whole hospital. So we will have time for questions and discussion. I think I don't have many more than maybe 45 minutes, so we will not have time to sleep too much. And then we will have some questions to stay alive, and we'll take a break before the second part. Maybe at first, Jean, just a short recall on accreditation in Canada, because maybe it's not the same in each of your heads. And then, starting on 1958, the whole movement for accreditation in Canada was supported at first, especially by Canadian Medical Association, Canadian Nurses Association, Canadian Hospital Association. So you can see that it didn't come from the government, and it did not come also from a law, from something compulsory. It's only that professionals at that time and those associations were at that time looking to have some standards to make sure that hospitals will evolve with the best practices for the population. So it started quite early, and you see it's in Canada, but today, at this time, we have in Canada more than 1,100 organizations who are accredited, but some organizations can have 5, 7, almost 10 hospital, primary care services, or maybe home care. But in Quebec City, was not a big city, we have a big academic hospital who regroup 5 previous academic hospitals. So this is one organization, but it would be 5 visits to be to surveys to be integrated if that hospital is accredited, and he is accredited. And then accreditation Canada, I'm not making any publicity because I don't work for Accreditation Canada. I only give around 10 days a year to do surveys in some other hospital, but I'm not here to sell you anything, but to have you know how it works, where it is implemented. And donc, yes, I think our ambassador told a few words about the tradition of quality of healthcare in Canada. Those red spot means the places where Accreditation Canada International is now working to deploy accreditation process. And I think you heard before about ISQA. ISQA is an international accreditation organization who accreditate accreditation organization. We have to look also at some international trends. You know, it's not a strange thing that your hospital or your organization are asking to themselves some questions about improving care, about patient safety, and then you see your government ministry trying to deal with those issues, and some react by compulsory things, some others have laws, some others have contracts. But what I saw in the few days I'm around is that it's complicated to have the whole picture to help you to mobilize your professional and your personnel to go on the way of continuous improvement. So when we ask you something that is hard to deliver and you don't understand very well why you should do only that thing, when you go to your professional and your personnel, they don't understand more than you, and sometimes it's the way to kill the beginning of a culture for continuous improvement. So we see health system reorganization in Canada and especially in Quebec province. In the last 15 years, we had two big movements. The first one was, we can see fusion, two hospitals who become together, we see fusion. Okay. It started with hospital, and then around maybe 6 to 7 years ago, maybe 1 or 2 years around, we link hospital with community services, so primary care, and with home care. So we now have health and social services center who can have 20 small organization, maybe 15 home care, maybe 3 community health services, and maybe at least 1 hospital. Not really 2, usually it's 1, with a catching area with quite equilibrate around the province. So that's what happened in our province. So it brings with it a lot of challenge for the continuous care, to acclimate different culture, to keep the patient in the center. You know what you mean. But it's not only in our country, I'm sure you're living the same, and it's not only here. So it gives us some pressure to do things differently. We also have, and you know more than me, the situation in Europe, and it's the same in America. Also, we have to make the best with the resources we have of all kinds. And then it's a big preoccupation. We also have in the center of those approaches the quality of care and patient safety. But sometimes some of our authorities see in the third a way to reach the second. it's not bad at first, but if it's the only thing we do to reach quality and safety, then we kill all nice initiatives. We also had changes in professional responsibilities. I don't know how it's going here, but in Quebec province, during the last year, the College of Physicians, this is the provincial order for physicians, you have another name here, I think it's a physician society, right? Something like that, had a lot of work with the order of pharmacists. And then we had a new law a few months ago letting pharmacists having a little bit more autonomy in some fields that were before only reserved to the physician. And it's welcome. It's welcome by physicians. It's welcome by other professionals also. I think it's around 5 years ago we had big works also on the way professionals have to work together. What's the real, what are the reserved practice for the nurse, for the psychologist, for the physiotherapist, for the social assistant, and all of that. And then we move over the profession, and then looking at the patient needs to serve, we can see sometimes in a team people having more responsibilities than their own profession gives. I don't know how to explain that very clearly, but it's a way we have changes in professional responsibilities. And I have a bad news for doctors and physicians. We had models before where the doctor or the physician was the one who was calling the shot in the clinical field. But now, having patients for which we have to address a lot of needs in a continuous pathway, the physician, the doctor can't answer all those needs and cannot prescribe solution to all those needs. So the physician is, we can say condemned, no, condamné, yeah, condemned to work with other professionals and to share at least some part of the way he worked before. And we saw a lot of hospital and organization, being late on that aspect, and they took, they stay behind, because what happened in those who succeed is that the doctors and physicians themselves just reorient the way they work in the teamwork, and other professionals like that, and they follow. So the doctor had to reinvent the way he works in a team, but it doesn't mean that he's go back and he don't. I think you understand also. The other thing is that more teamwork, sharing some responsibility, redefining professional involvement in quality and in patient security improvement. The physician can be the only responsible for safety and for quality of care. Public protection and professional mobility, I think you have the same, before people enter a hospital as a nurse, as any kind of profession, and they left when it was time to retire. It doesn't happen anymore. And this turnover of the professional and even the personal gives us many challenges to keep the continuity of care. And that push us to have more standards, to have more procedures to make sure that independently of who's working today, tonight, or tomorrow, we are quite sure we will have the same process to deliver care and being safe for the patient. Public protection is an issue also. And you know, people are more and more informed, and then they ask for a good quality of care, and they ask for safety care also. And you know, we find more and more people saying that one of their relatives died from an infection acquired in the hospital or had a complication. And then, you know, the newspaper, the TV, take that, and it's the big show. So we have that more and more. And patients come in our hospital also more informed, and they ask something I think they should receive. Research also of care improvement for collectivities help us, and transparency and more informed patients. That's what I said. I just recall a big study made in British Columbia, with the western province in Canada, and the university on his mental health and addiction services made a huge literature review on what are the big issues in mental health patient safety. At first, they found that it's a more recent field of knowledge, so it's documented, but not as much as in other specialty. And they found also that there was multiple causal factors in mental health, and that we have 4 main categories. I told you, because before going to the standards, before going to accreditation, to the standards in mental health, we have to look at the big picture, because the more we are going specific, we are only facing only a small part of continuous improvement and patient safety. So we have patient factors, provider factors, organization, and physical environment. I will not go very deep, but just have a quick look on each of them. For sure, discover also that there's difficulty in measuring all dimensions. So we cannot list all the adverse events that can happen, but we can find a lot with what we know and what literature or our own experience tells us. But we will not be able to measure all of them, but as you know and as you see, we have enough to work on. Recognize also one thing. What they found, it's interesting, that the more you take care of patient safety, the more you will have quite the same effect for your employees. That means if we're not preoccupied with patient safety, we can almost infer that our employees are exposed also to many factors that we can rule or diminish. Patient factor, I think as you are working in the field, you know all of them, but maybe it doesn't mean you work on all of them. Should we work on all of them? It's depending on the priority one organization want to address, depending on what happened. You had some situation, becoming in that item. So absconding, health harm, self-mutilation, suicide, you're not surprised of that. Aggressions toward others, importance of involving. So they conclude the day when they just, look at all the literature, that the more you involve the patient in his care, the more you inform him, the more you address, I can say, successfully patient safety issues. It's always coming from literature. It's 2008, not so old, Provider factors, attitude and inductive behaviors from professional, from employees of all kinds, patient overload and limited time with them. Those two are very important. You know, in our healthcare system, mental health wasn't, during the decades before, a field where even our government were paying so much attention. Right now, yes, but at one time, maybe not so much. And the budget, the way the care delivering was organized, we should have at that time one nurse in charge of maybe 50%. It's a bad example, but it happened. Maybe here also, I don't know. So that's what it means. And limited time with them, we made, I will talk about that maybe later. We had a good budget, to review all the, all the rooms in the hospital. We still had 6 people in the same room 8 to 10 years ago. And by the time we just make renovation, we adjust also the personal ratio, and we give, how can I say, des dossiers informatisés. A patient record on a computer, eh? And we grab some tools from everywhere in the world to have the professional, and especially nurses, to have more time with patients. The more time they have with patients, the more they know their needs, the more they can help, the more they have them being involved. That's what it means. Insufficient communication, that one is very important also. And you will see in the standards that communicate between professionals, communicate at a point of transition, being transfer, or going to another world, or I don't know. Information is a key. And we have staff turnover, inexperience, fatigue. And a conclusion on that item is that better feedback and team coordination leads to a decrease in safety failure. We also have organizational factors, so staff recruitment, retention, training programs, and all those topics. Patient admission and discharge processes. Those are 2 big activities to CERN, we can say, cerner, to scope on many aspects of the patient. Policies and procedures. We think it's something administrative, it's not for care deliverer, it's not for a clinical way to work, but it's not true. And in the whole process of accreditation, we should address that. But what happens sometimes, some make focus on that, and they have, that high of politics, procedures, and all of that, but nothing changed in the organization. So we need some, but we have to implement some who will give results for the patient or for the personnel. And then reporting incident and accident is a key. And in the accreditation process, those are part of the necessity you should address if you want to reach accreditation. And then lack of community resources, bed shortage, staffing shortage. So those are, but it's not only in mental health, it happens also in other specialty, but in mental health or psychiatry, our 2 main technologies are medication and the personnel who gives care. So those are our 2 technologies. We don't have many big machines, but our specialized technology are those two. And then they also pointed out that the consultation for psychiatric patient in general emergency will induce more safety issues than consulting in a general emergency where there's a place dedicated to a psychiatric patient. In the physical environment, inadequate constraint, overcoming accommodation without natural lighting, it's written lack of sleeping space, maybe it's lack of rest space, when someone becomes a little bit aggressive, we say just go there, take time, but when it's too crowded, we cannot do that. And as I told before, we just evolved one room for a patient. We saw isolation, contention, and all of that decreasing at a really fast rate. So that means it's quite true. Also safety, but you know all of that. So they just list the more important all over the fast review I made with you. And down you can see them, I think even in the back seat. And if you look at accreditation Canada standards, and you look at those being well focused on safety, safety care for patients, you have all of them. It's all included. Even violation of patient rights. Other risk, you are in the hospital, so you have, you also have, some equipment, you also have, what you can find depending on the way you are organized, but infection prevention is a really major issue also in psychiatric hospital, where people live for many weeks, sometimes many months, if not many years. And we also have a group with Canadian and international experts coming from mental health field, but someone who are in the peripheral area of mental health, who in 2008 also just tried with some researcher to focus on what should be done to help delivering better care for psychiatric or mental health disorders and safety. Stigmatization and discrimination. By the time someone comes in the hospital and it's written on the file, this patient is a psychiatric patient, you have the ambulance for a heart attack, you have the other thing, you have the other. Maybe this person is, is looking for suicide, but the file will be apart and will take care of the other one, that we think we will help better. And even in ambulatory care, it works a lot. So they pointed out that we all have to work on that objective. And I think many governments do things about that, many Ministry of Health, but we have to do our part also. Medication safety, I think you know that, suicide, false aggression, violence. Comorbidity is not new, but we are taking care of that more and more these years. Those people who are taking any kind of drugs, all of that is impairing with the psychiatric disorder. Accessibility and quality of care. Admission delays, discharge delays will have an impact on the safety of care. And then, it brings up that to address those multiple parts, we have to develop at first a culture of improvement. And by that time, we will start to address some of those issues, make progress, and then, we will never finish, but we have to start with the worst one if we can. And what they found also, and it's the same in my province, but I think it's less important in psychiatric hospital right now in my country. It's because we had 2, 3, 4, 5 cycles of accreditation on a 3 years basis. So when you're in the program since 3, 6, 9, 12 years, those issues that we are so different from other hospitals, that in psychiatric hospital, all the standards for the others do not apply to us. For me, it's not a surprise, maybe for you, maybe not. What they found, with proof, is that 90% of what is done for continuous improvement and safety in general hospital can apply to psychiatric hospital. It's very important to have this in mind. And then that the active participation of patients and their relatives is also a key for better care. Just a few words on accreditation, and maybe Sébastien can add more. It's only to recall the frame of accreditation and quality measurement. The first is to measure our services, in relation with international or recognized standards. The second is, to take accreditation as a tool to identify, have priority for improvement, and then to have a process to regularly and consistently, look at and improve our services. Accreditation is a kind of filter just to have an outlook of your organization and just fix the most important, and then having priorities every year with your team and reporting on them. In accreditation, we found, and those are from literature also, that it's an excellent framework, and it sets the bar for the level every time, being trying to go far in each area. Regular updated framework, develop contribution maximum defeat, that's okay. Mental health framework for, okay. We had at Accreditation Canada a working group with psychiatrists, family physicians, nurses, manager. It's not a very good big group, but it was quite representative of the whole country. And then they address, mental health for adults and children, what was applicable internationally and in the public and private sectors, and then to have an overlook on the whole pathway a patient have to follow in mental health services at any level. I want also just to give a picture of Accreditation Canada every year has an annual report, and the report is on some number like that, but also what are the big issues emerging from the surveys done in the year. So in 2012 there was 968 organizations participating in the Accreditation Canada program. That means on-site survey It could mean education program, something like that, right, Sebastien? And there was 326 organizations that had a survey during that year in Canada. And if you look at the kind of services who were accredited during the year, you see, because of the transformation I told you, this kind of organization can mean a hospital, community care, home care. It can mean also regional health authorities. We see provinces in Canada having many regions for delivery of service going to less and less and less and less catching area region. We see in New Brunswick, who is a small province, just nearby a regional authority for the whole health system in the province. It's huge, right? That's true, what I'm saying? And you know that, somebody also? Yes. And you see mental health. Mental health hospital are not so, we don't have so much. There's psychiatry in many general hospitals, but for specific psychiatric hospital that represent that year 5% of the organization who were visited. And you can see what kind of services can profit from an accreditation. I don't see that there, but I was part of testing the new standard. Our independent surgical clinic, almost performing aesthetic surgery, are now accredited with the Accreditation Canada standards. That one was a demand from our Ministry of Health to Accreditation Canada to say, I want to make sure that people, and especially women, going to those clinics for aesthetic surgery will have safety care and will not let their life in such clinic. So right now, all those clinics are accredited and have to, if not, they don't have a permit to operate.